Sorry, I see a computer, but I don't see what I am talking about. Okay, controversy in perforators. Why should we treat them? That's the first question to ask. Venous ulcers in C6, healed ulcers C5, lipodermatosclerotic legs, and of course recurrent varicosities and primary varicosities. Well, I'm certainly going to skip primary varicosities. I think for C1, C2, C3, there is no indication to perform perforated vein surgery as the first choice. It may be relevant for recurrent varicosities, but I'm not going to address that issue because I think there's enough data to support us to state that you do not treat perforators in a primary varicose vein patient in which you should treat the great or short saphenous vein. So why should we treat them? What's the pathophysiology? Well, we heard some things about the pathophysiology in ulcer disease, and this is the theory. At the high systolic intravenous pressure in calf veins, and that's also something which you should be aware of. If a patient stands up, it's the hydrostatic pressure which goes up to 90 millimeters of mercury. I'm not doing anything. And the other, but if you really use your calf muscle, then the pressure goes up to 200 and up down to 250 mils of mercury. And that high pressure can be transported to the skin circulation, and that causes the intermittent high systolic intravenous pressure. And that in fact causes white cell trapping and capillary cuffing. And that's something which is a known mechanism. And in fact, due to the fact that the distance between the cells who need nutrition and the capillaries increases, the nutritional flow goes down and you get an ulcer. So then you have impaired nutritional skin flow. That's the theory behind the fact that an incompetent perforator is significant, because the hydrostatic pressure can only be organized by the superficial system. If the deep system is not connected to the superficial system, you can never ever get those high pressures over calf muscle pump contraction to the skin circulation. So that's why the believers, I'm one of them, is that perforators do do cause pathology. There are some trials, and for instance, we know that from a review from Harvard, who put a long amount of a large data about conservative treatment alone in ulcer patients, and he showed a healing rate of 65% and 33% recurrence rate. And the reason why the recurrence rate is so high, that also relates to compliance. There is even a series from the late 80s in which it's shown that if the compliance is documented to be 0, so patients don't treat compressive stockings, then the recurrence rate in the conservative treatment is up to 100%. So there is something out there. If you treat the superficial system alone, and we know it from which trial is it? I don't recall it anymore. But if you treat only the superficial system, we know that the recurrence rate significantly reduces. So if a patient has an ulcer, and you should analyze the superficial and the deep venous system, and if there is incompetence of the superficial system, you need to treat the superficial system. It doesn't influence the cure rate, but it influences the recurrence rate significantly. More than 50% reduction in recurrences if you only treat the superficial system. Then of course, what's the additive value of SEPs? But the problem with those series is that they say, okay, SEPs didn't contribute significantly due to recurrences because, and that's where the problem steps in, that they say treat the incompetent perforators do not have any influence. But the problem with all those trials, in those SEPs trials, is that they perform SEPs procedures, but they never ever controlled after the SEPs procedures how many incompetent perforators they really treated and how many bad SEPs procedures were performed. So it's okay that you conclude that if you do a combined procedure, superficial with a SEPs procedure, that you have not a very high reduction in recurrences, then you should conclude that the SEPs procedure doesn't cause reduces recurrences. But it doesn't have, unfortunately, nothing to do with the conclusion that perforated vein treatment is not of any value, because we never controlled for if the perforating veins were well addressed. And there are data from multi-center trials who did 1 to 5 SEPS procedures in a year, and then you can imagine that the quality of the SEPS procedure is unfortunately low. The only randomized trial which really conducted is by Van Gent. He did in 200 patients, and but there were also lateral located venous ulcers included. And at that time, we showed that the healing rate was not significantly different between the both groups, and the recurrence rate was still high. But if you look at subgroup analysis of this, and in fact take out the lateral ulcers, then you see there's a significant increase in benefit for the patients treated with the SEPS procedure if they have a medial ulcer, a recurrent ulcer, or a large ulcer. And if you look at the complete group of this randomized trial, then this is 87% of the total group. And in fact, the 13% are the lateral SEPS procedures, and they are abandoned. And we know already from other studies and anatomical studies that that's not the way to treat laterally located ulcers. So in fact, in my opinion, this study already shows that people with medial, recurrent or large ulcers will improve their quality of life and their ulcer recurrences after SEPS procedure. This is the graphics of these data with a long follow-up. And then we looked at, as I stated, the quality of the SEPS. If the quality of the SEPS really influences the outcome. And we defined that if you leave 0 or 1 incompetent perforator in the area which you want to attack with the SEPS procedure, then we call this a good operation. If you leave more than 1, then in fact the procedure is not conducted the way we want it to do. And you see in these data that you have a 50% recurrence rate if you didn't perform the procedure well enough, so you leave perforators, and you have only 16% recurrence rate if you treat them all, or leave 1. And so in fact this shows indirectly the relevance of treating incompetent perforators for recurrences. It doesn't relate to healing, but we know that every ulcer can be healed. If the compliance is okay, patients wear their compressive garments and the ulcer heals. But after the ulcer has healed, then the compliance goes down. So then you're really left over with the fact that how is the hemodynamics improved by treating the incompetent veins. And if the incompetent veins are well treated, and the superficial system of course too, then your recurrences stay low, although they don't wear any compressive stockings anymore. So compliance is optimal during ulcer when it's active, but it goes significantly down, at least in the Dutch population for sure. It goes down after the ulcer is healed. So that's where you show the significant influence. Here you see the healing in this well or not successfully performed SEPS procedure is about the same. And here you see the big difference in a successful SEPS procedure with a much lower recurrence rate than in the non-successful SEPS procedure relating the influence of perforators. So why treat incompetent perforators? Well, because indirect proof is that there is a clinical significance of incompetent perforating veins in C6. That's what the SEPS trial and the analysis of the well or not well performed surgical procedure has shown. And on the randomized data itself, we can show that the clinical outcome is better in C5, C6, medial ulcers, recurrent ulcers, and large ulcers. So what about the complete group? So yes, we should perform incompetent perforating treatment in C5, C6. In lipodermal sclerotic or recurrent ulcers, we don't have any data which support to do it or not to do it. We don't know. There have to be trials. And as I stated when I started, primary varicosities veins should not be treated. If you allow me some time, I don't know if I have 2 minutes, 1 minute. Very fast, I will show you what kind of treatments there are. We start with the Linton procedure. I think it's obsolete. There has been randomized trial to show that the wound problems are too big. Edwards tried to minimize wound problems by a half-blind method, and he destroyed perforators nicely, but he destroyed unfortunately much more. Then we got the SEPS procedure. We did a 1-port system, and we know that Peter Klavitsky did the 2-port system with the laparoscopic equipment. Both equally the same in the success of treating perforating veins. Now we have new method, sclerotherapy of incompetent perforating veins. Very nice in primary success, but unfortunately 33% recurrence after 1 month. We don't know if foam is going to do better. There are no data. Cryoperforating surgery, and you freeze attach the perforator to the probe and you destroy it. We tried it with 2 types of probes, doesn't work, obsolete. Radiofrequency ablation, you have to go intraluminally. It's difficult. The success rates published are the data that you are successfully to get into the vein. But in our hands, we're only in 70 to 80% accurate in getting into the vein, and the rest we don't get into the vein. So it might be a good one-hand procedure. Laser, same, you have to be inside. If you're inside, it's probably a good method. We also tried it with coil embolization. Very nice initial success, but recanalization 75% after 1 year. Forget it, it's obsolete. And then we have the indirect method. Drive with a hook to drive on the superficial, over the fascia, and just destroy it. We don't know if this is going to make it, at least it's cheap. So in general, we have all kinds of methods to treat them. If you believe you should treat them, you have sepsis first choice in our opinion, sclerotherapy, a high recurrence rate, cryo perforating surgery obsolete, venous and RFID are still there, laser is there, coil embolization shouldn't do anymore, and duplex interruption, we don't know. There are new things, steam, glue, we don't know how it's going to work. Thank you.